Our next speaker is an amazing man. It's Anthony B. Iton. He's an MD, JD, MPH. He's the Senior Vice President of Healthy Communities, and he joined the endowment in October of 2009. Iton, who has been published in numerous public health and medical publications, is a regular public health lecturer and keynote speaker at several conferences across the nation. He earned his BS in neurophysiology with honors from McGill University in Montreal, Quebec, his JD at the University of California, Berkeley School of Law, and his medical degree from Johns Hopkins University, their School of Medicine. Ladies and gentlemen, please welcome to the stage Anthony B. Iton.
Thanks very much. Wow, it's really bright out here. Okay, so I'm going to go fast because 15 minutes, and I usually talk for 45 minutes and then get warmed up. So first of all, it's great to be in Indianapolis. One of my best friends is from Indianapolis. He has like 5 brothers, all from Indianapolis, and he grew up getting beat up by these brothers every day of his life. So he's really happy to be in California where he doesn't have to take a daily beating. So I try to oblige him by trying to beat him up periodically, but it doesn't bring him home. So let's see, how do we get started on this thing? I press this thing. First, I have to disclaim everything that I say. These are my opinions. I sit on the CDC Directors Advisory Committee. I work at the California Endowment. I used to work at the Alameda County Public Health Department. And everything I say is what I believe, not necessarily what these people believe, although quite frankly, a lot of them do. So very quickly, I'm going to talk about why place matters. And to do that, I think it's easiest to talk about where I grew up. And if I had more time, I'd have you guess where this place is. Maybe I will, although you heard a little bit about where I went to university, so maybe you already know. But this is a beautiful city, not in this country. It's an old volcano island. It sits in the middle of a river, and it's very, very old. It held the 1976 Olympic Games, the 1967 World's Fair, and I grew up there during a time when there was a lot of investment in the community and in society. I went to university there. This is actually a view of that university from looking down on the mountain. The city is Montreal, Canada, just for those of you who haven't guessed it yet. That's McGill in the foreground, and you can see downtown Montreal in the background and the St. Lawrence River beyond that. And in Canada, you have universal health care, you have universal dental care up until the age of 12, you have highly subsidized child care. I went to McGill University for free. And I could have gone to McGill Medical School essentially for free as well. And what that did for me, I believe now in retrospect, was it gave me a sense of belonging, as Terry was referring to, a sense that this society had invested in me, that I had a lot of value. And I think that that has carried me through my entire life to date. When I was 22, I decided to leave Montreal to go see another city, and I chose Baltimore, Maryland, because that's where Johns Hopkins Medical School was, and then Johns Hopkins' credo was, we may not be the best, but there's nobody better. And so I said, well, this has got to be a great place. Let's go study health care at Johns Hopkins. And when I got there, this is what I ran into. And I walked around the streets of East Baltimore. This is immediately adjacent to Johns Hopkins Hospital. And I was in shock. I literally didn't know what I was seeing. I had no frame of reference for this. And I was with somebody, and I asked them, I said, when was there a war here? Because literally, this was the mid-1980s, and my only reference for blight like this was Beirut. And I assumed somebody had dropped bombs on this place. And I'll never forget what the guy said to me. He said, what do you expect? It's the inner city. And I said, what do I expect? I'm supposed to expect this? This is supposed to be a norm? This is okay? And you've got a name for it. You call it the inner city. It's a place where you wall off society's problems that you really don't want to deal with. And you know, from that day, I've been trying to explain what it would be like, been trying to explain to myself what it would be like had I been the kid in this picture growing up in East Baltimore, not growing up in Montreal, Canada. What would I have been like today? And this kid did not create these conditions. What do we owe this kid is the question I've been asking my entire professional career. I go back to Baltimore periodically. Actually, Chris Gibbons, who's going to be speaking soon, I've met him. He was at Hopkins for quite a while. And these are pictures taken at Johns Hopkins in the immediate vicinity of Johns Hopkins last year. This has not changed. And of course, you all know about this, what's happened in Baltimore recently. And the national news would look at these stories and try to understand what's happening. And I was like, this has been happening for 50 years in Baltimore. It's just nobody's looking. Okay, so the big question for me since that time was, does your zip code matter more than your genetic code when it comes to your health? And I think the answer is yes. I'm going to try to prove that to you very quickly. So this is a death certificate. I was a health officer in Alameda County, California, which is where Oakland and Berkeley are. And when you're the health officer, you're literally the registrar of all births and deaths. So you get very good data, and you could take a death certificate and find out what somebody died of, how old they were when they died, what their race, ethnicity was, and where they lived. And those 4 pieces of data can actually paint a very compelling picture of death in a community. One of the things that we were able to do is look at death rates over time, or life expectancy over time, going back into the 1950s. And when you do that, you can only do black and white, because the census didn't really start talking about anybody else until really about 1990. So if you want to go back before 1990, you can only talk about black, white, and other. So in 1960 in Alameda County, the life expectancy difference between blacks and whites was 2.3 years. 20 years later, it had more than doubled to close to 5 years. And then 45 years later, it was almost 8 years. And this was during a time of a revolution in healthcare. MRI, CT scans, minimally invasive surgery, all sorts of new pharmaceuticals were happening, yet this life expectancy differential was growing. A lot of people ask us, well, isn't this violence, this homicide, and HIV/AIDS? So we actually did the analysis and calculated whether it was violence, homicide, HIV/AIDS, and it wasn't. This is chronic disease. This is heart disease. This is lower in respiratory disease. This is stroke. This is not being driven by anything esoteric. Infant mortality plays a role, but not a big role, because the number of deaths is relatively small, and the number of deaths in the county every year is about 10,000. So this is driven by differences in chronic disease, nothing esoteric. Just to show you what this looks like on a map, this is San Francisco and the San Francisco Bay. This is Alameda County. It's shaped like a boot that is very much interested in trying to crush San Francisco. Haven't quite gotten it done yet. But you can take the death certificates and you can actually map life expectancy beyond the zip code level. You can actually go down to the census tract level. There's enough data, if you spread it out over time, you can actually go down to the block level if you want to. And so this is what we did in Alameda County, and the green areas where life expectancy is routinely greater than 80 years. The red is less than 74 years, and the yellow is in between 74 and 80 years. And you see that there are concentrated hotspots of premature mortality in Alameda County. And I used to show these maps, years ago, and people would say, oh my God, I don't want to live in Alameda County. So we had to start doing this in a lot of other places. This is Cuyahoga County, Cleveland, to show that actually has one of the most significant health disparities I've ever seen. This is Baltimore, Maryland. I had to go back to Baltimore and take a look at that. Baltimore has neighborhoods with life expectancy on the order of 55 years. I still don't believe that, but I do believe it, but I can't accept it. This is Los Angeles, California. This is Seattle, King County. This is New York City. This is Philadelphia. This is Minneapolis, St. Paul. This is Boston. Here in Indianapolis, a great report was done talking about gaps in life expectancy in the Indianapolis metropolitan area. And they found this dramatic 14-year life expectancy difference. If you can see down from the bottom at 69.4 years and up towards the top at 83.7 years. A dramatic difference right here. This was in the Indianapolis Star I saw the other day. I figured I should show it to you in case you haven't seen it, in case people don't read the Indianapolis Star, I don't know. Indy zip codes life expectancy lower than Iraq's. Why? I mean, so this is real, and this happens everywhere we've looked. We've found these differences with one exception, which I can talk about later. The other thing you can do, if you're a data nerd like me, is you can actually put life expectancy and poverty at the census tract level in a correlation. Just looking at, for every one of these census tracts, there's a life expectancy level and a poverty level, and you can correlate them. It's called the bivariate correlation, very simple to do. Life expectancy is on the up axis. So as you go from bottom to top, you're going from shorter lives to longer lives. And as you go from left to right, you're going from relatively wealthy communities to relatively poor communities. And as you move from left to right here, life gets shorter. So there's a cost to living in a low-income community that you can measure, and you can predict how long somebody will live based on their address. And so we did that. That was Alameda County. We did this for the San Francisco Bay Area as a whole, which is 6.5 million people. We did it for the entire state of California. In the San Francisco Bay Area, we had to translate this because people don't like looking at bivariate correlations, particularly in the newspaper. So we translated this into something that people could understand. We took the slope of that line and just monetized it and translated it to $12,500 in household income buys you a year of life. That's the cost of life in the San Francisco Bay Area. And we would jokingly tell people that next time you're negotiating your raise, this is the kind of data you need to bring to the table. You need to be like, hey boss, I need a couple years. I've been working hard this year, I've been, staying late. And the boss is like, well, Tony, I don't know, that report on the Johnson affair was a mess, and I see you getting 6 months this year, 6 months tops. So just so that people know, and this is a shortened version of this, but disparities are important and they are profound. But in the United States as a whole, we have poor health. So even what we're comparing to is not good. The life expectancy of white Americans, let me just tell you about it, it's about 78 years, 79 years now, 78.74 years, which is equivalent to that of Chile, Costa Rica, Denmark, and Bahrain. But it's shorter than Belgium, Kuwait, Malta, Portugal, Slovenia, United Kingdom, Austria, Cyprus, Finland, Germany, Greece, Ireland, Netherlands, New Zealand, Norway, South Korea, Andorra, Australia, I still don't know where Andorra is, Canada, France, Iceland, Israel, you can read the rest, Japan, San Marino, Switzerland. There are 32 countries in the world with longer life expectancy than white Americans. 10 years ago, there were only 23. The life expectancy of white Americans is getting worse, relatively speaking, compared to developed countries around the world. This report from the Institute of Medicine basically shouted this from the mountaintops, comparing the US to 17 peer developed countries. The panel was struck by its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. And this health disadvantage cannot be fully explained by health disparities. Several studies are now suggesting that even advantaged Americans who are white, insured, college-educated, or upper income are in worse health than similar individuals in other countries. In 2012, in Health Affairs, there was a report that looked at life expectancy for white Americans at different educational attainment levels and found this very disturbing finding that for low-educated white American women, life expectancy has been decreasing, and it's been decreasing for quite a while. And then just recently, this was 2 days ago in the New York Times, a big story about death rates rising for middle-aged white Americans, which has generated, according to the New York Times, more comments and more forwards than any other newspaper article in the New York Times in the past 5 years. So this is big news. People didn't know this. Those of us who've been in epidemiology and public health for a while have known this. Can you cue the video, please? I want to show a quick video of that we're trying to use to explain why we work at the place level to try to address these health disparities. And I'm hoping that somebody heard that. Oh, yes, good.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, around 4 miles away. They're similar in so many ways, but here's the thing. On average, residents of B-Ville will die 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb's and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher. And there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventative health care. On the other hand, Beeville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhaust from the nearby highway. And for food options, Maria's only choices are Beeville's many liquor stores, fast food places, or convenience stores. The schools in Beeville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, not having the same healthy options as A-Town can be overwhelming, a constant source of stress and a health issue. In fact, for all the residents of Beeville, it drives health problems like obesity, diabetes, asthma, and heart disease. And how did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, it began with racial discrimination. Over the generations, poor people and people of color were pushed to less desirable parts of town. In those neighborhoods, banks refused to lend money. Businesses left, jobs too. Schools declined, and the neighborhood crumbled. Everyone who could move away did. And here's the thing, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, or upper income, die younger than their peers in other countries. In fact, our life expectancy is 42nd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality. Inequality hurts us all. So what do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow, we lead. We are making health happen in communities across the state. We are coming together to build one California, a smarter, healthier, and more equitable state that creates opportunity for all of us. Join us. To learn more, visit calendow.org/buildinghealthycommunities.
Okay, so I'm going to end there with just the conclusion that these issues are not the kinds of things that can be solved one person at a time. And that's what we've been trying to do in public health and medicine. And while it's important to actually attend to people in immediate need, we also have to be able to look at the structures and the politics, quite frankly, that create the conditions that generate this kind of constant stress and injury that lead to disease. Thank you very much. Those are nice socks.
Thank you very much. That was wonderful. And I love the A-Town and B-Town because those of you who know me know that I live in A-Town. I live in Fishers, Indiana. I live in Hamilton County, #1 health status, best economic status. I work in B-Town. I work in Marion. I work at Eskenazi Health. And one of the things that frustrates me, and Terry alluded to this, the Speaker of the House of Indiana is my representative. The head of the Senate is my senator. The people who are making the decisions about what happens in B-Town are oftentimes removed from B-Town. And one of the things I want you all to remember is that Anthony's on the CDC Advisory Committee. And one of the things that frustrates me is that we try to come up with national policies when it comes to grants and other things that are determined by people who work in Boston at Harvard, and people who work at Hopkins, and people who work in LA, and people who went to Berkeley. But people who live in rural Indiana don't have the capability, don't have the assets. There are many barriers for them to be able to get these grants. How do we fix that? How do we develop national policies and national grant applications for regions that are so very different?
Yeah, well, I think one of the biggest challenges in this work is to get people to understand that it is not a zero-sum game. So people in Scott County, Indiana, who are suffering an HIV outbreak are suffering a health status problem, but it's not just their problem. Those problems and the concentrated inequity that happens in our country throughout actually brings the overall health status down, and it affects even people that live in your community. And that's part of what we're trying to get people to understand that, you know, if you think.
How do we convince people of that, though? How do we convince A-Town that B-Town matters to you?
Well, I think it's, you know, in part, you have to get people to recognize that there's consequences for people in A-Town. And the other part of this is that we have to recognize that solutions for this don't come from the top down. Solutions come from the bottom up, which is part of why our approach to this work is really to work in B-Town, to help organize people, to help them set the agenda for what impacts them, to help them essentially, the people that are most impacted by inequity, participate in reshaping some of the structures that create the conditions that they have to contend with. And, you know, I think that there are people at CDC and in Boston and Harvard who know this and care about this, but they all recognize that this can't be about us telling people how to live their lives. We have to enlist them to participate in, and as Terry was speaking to, this notion of belonging. People have to participate and be heard in the decision-making venues that actually create the conditions in which they live.
So what is CDC? What is Robert Wood Johnson? What are some of the larger groups doing to empower and bring those people to the table? Because you're right, I've been to these meetings and there are people who know and people who care, but as Terry mentioned, it still doesn't change the fact that the people at the table don't represent the people who we're trying to help and empower.
Well, as you probably know, I've been a pretty big outspoken critic of some of these approaches that are top-down. And I think that organizations like Robert Wood Johnson, the California Endowment, Robert Wood Johnson is working on the culture of health now, which is really kind of a comprehensive look, which is inviting essentially a broader spectrum of people that are not just health care, to look at some of the structures that create the conditions in which people live. I mean, quite frankly, you can take health out of the equation. I mean, I'm not saying we should, but you could, because the issues, the structural issues here relate to education outcomes, to employment outcomes. This is not a health issue exclusively. And so in order to address these issues, you have to blow up the silos and actually get people to work together. I call them the butcher, the baker, the candlestick maker. They have to come together to make a meal in community. And they have to have essentially the ability and the resources to work together across these traditional silos.
And that's one of the things I hope comes out of this afternoon. We've got many different people who represent silos in the audience here, and we need to bring different people into the equation. And for instance, for infant mortality, maybe patients, maybe other non-traditional partners. In Scott County, we had to bring law enforcement to the table, and that's not a traditional health partner that you think of. Are there any other partners you can think of that people in this room should be reaching out to?
Well, quite honestly, I don't think that there is a partner, a traditional discipline or domain that doesn't have a role. I think that what we have to remember is that the real experts, and Terry said this, I think, quite well, are actually the people who live in the communities that are experiencing the conditions. And one of the things we tend to do is we tend to treat them one at a time. We bring them into a room with a person like me, and we say, I'm an expert, do as I do, not as you do, and you will be better. And the truth is, we don't live the same experience. We're not experiencing the same conditions. And what we've learned is that when you actually take people living in these communities and bring them together with peers, people otherwise similarly situated, they can help each other in ways that I could never help. Because first of all, they find that they have something that they can offer, which is health protective. When you feel like you're an asset, you actually feel empowered. It gives you agency. The second thing is that they learn from others that are similarly situated, that understand the conditions, and they're much more likely to sort of engage in that kind of peer-to-peer exchange, that they have some, you know, smarty pants pinhead in a white coat telling them how to live their lives. That would be me, by the way.
Well, me too. So we're two peas in a pie. Well, Carlos is giving us the hook, but thank you so much. That was wonderful. And can people, if they want that video,
You cannot have the video yet. We're working on a guest special narrator. So as soon as we have that special guest narrator to narrate it, it will be available to one and all.
Great. Thank you so much.
Thank you.